meeting and conference. The usual question that we usually ask now is fluorescein angiography or OCT angiography. And I hope by the end of my presentation we'll have the decision, but I'm especially concerned with the diabetic macular edema, not any other medical or retinal problem. As we all know, the perfusion being the superficial and the deep retinal layer, this is now confined with the OCT angiography to separate the perfusion in even three main layers, the superficial, deep, and the choriocapillaris. And the pathology of the diabetic macular edema is mainly the retinal ischemia, which gives all the sequences of complications other than the exudative part with macular edema. And the retinal ischemia, which is mainly we are concerned as regards vision with the macular area, with the foveal avascular zone. And to have this beautiful picture of the capillary network in the foveal avascular zone, this is my own photography. It's not from the literature. And from a fundus camera, an ordinary fundus camera, an old Topcon fundus camera. I am not having any financial interest in anything, but I mean how the capillary network we should be concerned with, because this is the first and the very important point that we comment upon for the patient in the report, because this might be the only cause for drop of vision, which is the macular ischemia. And giving the foveal avascular zone, this is a fluorescein angiography. We can comment upon the irregularity of the foveal avascular zone, the fragmentation of the capillary network, the invasion of the collaterals due to the chronicity of the macular ischemia, and the starting of these telangiectatic vessels. All these we can carry with a good fluorescein photography in the early phases, because in the late phase, with the haziness of the interrupted blood retinal barrier and the diffusion of the dye itself will be hazy in view, especially if the patient is in early cataract. But as well, the fluorescein angiography having the advantage of being giving all the retinal peripheral details from ischemia to new vascularization and the extent of new vascularization, and to categorize the risk factors for diabetic macular edema or diabetic retinopathy. Also, it's a documentation for the patient and follow-up after laser therapy, and to know the sufficiency, the efficacy of the laser treatment and the deficient areas and the regression of these new vascularization, as in such a case of follow-up after PRP and the regression of the new vessels. Also, it gives the dynamic flow of the dye in the vessels, which might give us, like in that case, a swollen disc in a diabetic patient proved to be an anterior ischemic optic neuropathy or diabetic papillopathy, and to differentiate between papillopathy and the new vascularization abnormal vessels, or if it's an optociliary shunt at the vessels. So this also is the dynamic process of the dye. On the other hand, we have the disadvantage or the complications, side effects we can meet with the dye, from anaphylactic shock up to allergic, simple allergic manifestations. Also, the vascular occlusion and the extent of the vascular occlusion with the perfusion of the vessels is also taken upon. But when we came to the OCT and the introduction of OCT, I will go on very rapid for the sake of time, that the OCT biomarkers are very important, which added a lot in the management and the conclusion of the macular part, starting from the cystic spaces and the calibration of the cystic spaces to put the degree of the prognostic visual factors and the vitreoretinal interface, epiretinal membrane, vitreoretinal interactions, the subneurosensory edema with the exudation in the macular area, as long as the correlation with the choroidal vascularization, which is very important, of the perfusion of the vessels, the interrupted intraretinal septa with carrying bad prognosis. All these are additive factors for OCT in cases of macular edema. And of course, the choroidal vascular perfusion factor. Coming to the newest technology in the OCT angiogram, which added on the separation, as we all know, of the layers to superficial, deep, and the choriocapillaris with the whole vascular perfusion in the vascular density map. And this is the data we can take according to the size. We can use, of course, 3x3, 4x4, 6x6. Now it's 12x12 and the ultra-wide field OCT angiography, which will add a lot in the medical retina. The capillary dropouts are very obvious with the irregularity in the foveal avascular zone in such case. And this is an ischemic diabetic maculopathy where the OCT angio, as you all know, it's a dry and well-defined. There is no haziness from the transudation of the dye in the posterior highlight phase. So it's very, very well-defined and demarcated. It's more demarcated only by one shot in a second for the patient, which is very convenient to the patient. And this is a case in which I was here there is diffuse macular edema, parafoveal non-center induced involved macular edema, where the OCT angio showing the microaneurysms in the deep retinal layer, which is we are concerned with more in diabetic macular edema rather than superficial, which are affected. And here, like this focal lesion, where microaneurysm leading to this cystoid macular edema, it can be obvious in OCT angio. But again, to ask the question, we'll request fluorescein angiography or OCT angiogram in diabetic macular edema. This is a case with the foveal avascular zone with dye injection with fluorescein angiography, and the same case with OCT angio, where it is more defined, more evident, more obvious, but we didn't comment anything about the retinal periphery. Another case in which there's by the OCT, there is almost nothing to be concerned with in the macular area. And it's obvious in the OCT air, though I am using only 4x4, there are capillary dropouts in the periphery with fine irregularity in the foveal avascular zone, but we can see the motion artifacts because if the patient is that not well cooperative, it will have some artifacts. And in this case, we can see the hypoperfusion, though again, there is nothing to worry about in the OCT and in the fundus. May I have 1 minute? OCT angio will see the hypoperfusion in the vascular density map, but the same patient, I did him fluorescein angiography showing the ischemic areas in the retinal periphery, putting him in a severe non-proliferative diabetic retinopathy, though in the macular area there was no obvious manifestation. Another case, fluorescein angiography showing the paramacular capillary dropouts with early new vascularization at the disc. Here the capillary dropouts is seen in the same patient doing OCT angio, though again I am using 4x4 scan, not more because the resolution is better in 4x4, but the new vascularization at that stage of using 4x4 not evident. It can also see if it's an old vein occlusion, and it's not that obvious because here there is in the colored photography showing pre-retinal hemorrhage. I thought it's an ordinary proliferative diabetic retinopathy, but by the OCT angio it came to have a sectorial capillary dropout with collateral vessels, which is obvious of an old vein occlusion. Motion artifacts might and the cooperative patient might be more hindering factor in OCT angio, and the proper segmentation and the shadowing effect, all these have learning curve in OCTA. Fluorescein angiography being obvious in showing the new vascularization and the 4-quadrant assessment of the retinal periphery is very obvious. Here another case showing with the dye new vascularization in the periphery, though in the macular area nothing to worry about except some hypoperfusion or hypointense shadowing in the vascular density map, but we have the risk of dye injection and the precautions we should take with dye injections in allergic patients especially. So diabetic macular edema, the retinal periphery is very important to be documented upon. But comes the wide field OCT angio, where we can take the 12x12 and even the whole posterior pole, and the new technology with the rapid speed of the swept source and even the spectral domain OCT in some apparatuses might allow us to have a definite wide view assessment without dye injection. might help a lot in our practice, fearing of giving dye injection. But again, I can conclude that the macular perfusion is very important, and this is fully can be assessed by OCTA. But the fluorescein angiography being and will still, and I think it will never die, because gold is old is gold, as we all know, that it's very essential in other types of retinal vasculitis and retinopathies. So we'll not one day will not get rid of dye injection. But in diabetic macular edema, OCT of course is mandatory. I can't take a full assessment of the patient without giving the full assessment of the macular area, vitreoretinal tractions, macular assessment, and macular thickness, which is the last one to be commented upon, the macular thickness. But all the OCT biomarkers that we rapidly went through is very important to be documented. And OCT angio being non-invasive, rapid, safe, very convenient to the patient, it will have the upper hand for the coming era. But we said before that OCT, to be complementary to fluorescein angiography, which this in diabetic macular edema will put underlined marker, because what about the coming wide field OCTA and even OCT photography, wide field OCT photography might hesitate the use of fluorescein angiography for the coming era. Thank you very much for your attendance, and on behalf of the Egyptian Society, I invite all of you for the upcoming conference in Cairo in 29th of April, and it would be a pleasure for you to attend and join. Thank you very much for your attention.
Thank you, Dr. Nihal. Any questions from the audience? Can you give a microphone, please? Just a second, please, to hear the question.
Thank you.
Thank you.
Is there any difference in the clarity of what you can see in case of media opacity between the OCTA and the FFA?
FFA in media opacity, it might hinder the visibility, but early photography, I usually have the first 1.5 minutes, not more than that, because media opacity will affect at that stage the fluorescein angiography. Of course, OCTA according to the density of the media. If it's dense media, of course, it will hinder it more than fluorescein angiography. And the more it hinders OCTA is the media opacity and also the fixation of the patient. It depends on the fixation of the patients and the blink of the patients more than, because if motion artifacts are too much and the blinking artifacts are too much, you will not comment upon, it won't give you a good photo for OCTA. But fluorescein angiography, the patient might externally fixate more and be more cooperative. And the media opacity in both, it will hinder according to the density. If it's posterior subcapsular cataract, I think it will mask more the media for both of them. Okay. But of course, OCTA is much.
Thank you.
Quick answer for this question also, it depends on the type of OCT you are using. If you are using swept source and minimal nuclear cataract, you will have a very good view. The worst thing is the cortical cataract. So if you have a dense cortical cataract, nothing will work. But if you lose the early phase of fluorescein angiography, sometimes the patient is irritable. You cannot get the early phases. In the late phases, OCT angiography is much better than fluorescein angiography. And you still can get some idea what is going on in the macula. With the wide field OCTA now, with the 400,000 scan, whatever the opacity is, sometimes it penetrates, it can go deep, peripheral, central, it will be very helpful. So I think the Chinese instruments coming in the market now will replace fluorescein angiography very soon.
And I tried it on a very uncooperative. They got me one of the sales in the company, which she was very uncooperative, and a perfect scan.
Yes,
we took.
It's much better because it's 400,000. It's very quick, very reliable, and I think to get details, not the real angiography, but to get what's going on at the center and at the periphery. Another question over there.
In your experience, if the media is clear in both cases, if we want, my question is, which is superior to assess ischemic macula, OCT or FFA in
OCTA.
clear media?
OCTA. OCTA.
OCT angiography.
Yeah,
OCT
OCTA
angiography.
or fundus angiography?
No, OCT angiography. If I am not taking in consideration the retinal periphery, OCT angiography. OCT angiography for the macula is a perfect technology, because whether it's diabetic or a non-diabetic maculopathy, it's a perfect technology. It will get you even telangiectasias, which will miss it by any other means. If telangiectasia, if I'm suspicious of telangiectasia, the only mean of getting a good telangiectatic picture is with OCT angiography.
Thank you.
And also there is a correlation. I did a series of patients when we started working with OCTA, and I published it. You remember, Dr. Magzi, in the OCT OCT University, the correlation between OCT angiography in diabetic patients having no diabetic retinopathy, not even a single microaneurysm. I got a series of 150 patients, and all of them, after 10 years, they develop ischemic changes in the deep retinal layer. And this was my conclusion. So OCT angiography for this part especially is, but fluorescein, I repeat again that it will remain and will never die as regard vasculitis. To have a dynamic flow of the dye and to see the dynamic flow of a dye in vessels, this is the indication for angiography.
To put an end for this, because you are talking about OCT angiography plus OCT. Once you do angiography, you don't do angiography alone. You have a structural OCT combined. So it can replace fluorescein angiography in the central area. We are not talking about OCTA alone, because if you want to go to treat the patient, if it's ischemia or not, yes, OCT angiography will answer the question. But if there is an edema or not, OCT angiography will not answer that question if the edema is not involving the fovea, if there is no cyst. So combining structural OCT plus OCT angiography, really it replaces the fluorescein angiography in real life practice in 99% of cases. About the periphery, the upcoming white field will solve this problem. But again, fluorescein angiography versus OCT versus fluorescein in the macular area, I think structural and OCT angiography will and is replacing fluorescein angiography.
Yes. Yeah, I never inject fluorescein anymore for any AMD. For age-related macular degeneration, I never use it again. Even if I'm not convinced with the OCTA, I take the structural B-scan. Yani sometimes it's very low, stagnated or low flow in the choroidal neovascular membrane that I can't get. Yani I have in the B-scan a huge CNV, as I will comment. I do OCTA, I find trivial of pathology. So I omit at all the OCT angiography in that case, and I go for, because the stagnation, I go for the B-scan. Because the stagnation in the vessels, which is the main technology for OCTA, is the flow of RBCs in the vessels. So if it is stagnant and low flow, it will not give the shadow effect of the abnormal vessel. So I go for the B-scan, structural B-scan. But now, I don't remember a case for the past, we are now working about 10 years with OCT angio. I never